Welcome to AETCM, the emergency medicine channel. Shall I? Yeah. Today I'll be presenting a case of 63-year-old man who presented to ER with complaints of breathing difficulty and chest pain. On 10-second assessment, patient was conscious and oriented. Patient was having respiratory distress on talking one full statement. Airway was patent and there was no pooling of secretions. Coming to the breathing, patient had a respiratory rate of 38 per minute and a saturation of 90% at room air. Patient on auscultation, air entry was bilaterally equal and patient had a right-sided wheeze. At this point of time, we had connected the patient to oxygen via mask, and at 6 liters of oxygen, patient was maintaining a saturation of 97%. Coming to the circulation, patient had a BP of 180/110 mmHg with a pulse rate of 108 per minute, and there was fullness of JVP. At this point of time, 2 IV large bore cannulas were put and samples were taken. Disability, patient had a GCS of 15 out of 15, and on exposure, patient was febrile and had a GRBS of 155 milligrams per deciliter.
So what are the DDs at this point?
Patient was in severe tachypnea and having respiratory distress, and we had a DDs of patient is a known case of carcinoma right lung, so we had DDs of pleural LRTA. It can be due to pleural effusion can be there. Then we had diagnosis of pulmonary embolism can be there, pneumothorax can happen, pericardial effusion can be a cause. These were the DDs kept in mind.
Or MI also. MI that has led into cardiogenic pulmonary edema. Okay.
Coming to the adjuncts of the primary survey, since the patient was complaining of chest pain along with the breathlessness, we had taken an ECG, and in ECG it was showing a sinus tachycardia. Along with the sinus tachycardia, there were low voltage complexes in all leads, and in the precordial leads there was showing a mild electrical alterance was also seen.
Okay. So when will you define, when will you call as low voltage complex?
Low voltage complex, usually we see low voltage QRS complexes in the chest leads if it is V1 plus V2 plus V3 less than 30, or in the leads 1, 2, 3 less than 15, we can call it as low voltage complexes.
No, ideally in the chest leads, precordial leads if it is less than 10 millimeter, and in the limb leads if it is less than 5 millimeter. Only that much. Chest leads less than 5 millimeter, limb leads less than 10 millimeter. It is called, chest leads less than 10 and limb leads less than 5 millimeter is called as low voltage complex. Okay. So why is, you also notice electrical alternance. Why is electrical alternance happening?
Usually electrical alternance happens when there is a amplitude of QRS complexes varying from one beat to another beat, and it happens when the heart is floating in the fluid. Can happen.
Swinging heart. If there is a pericardial effusion. Okay.
So after taking the ECG, we had a suspicion of pericardial effusion, and then we did a bedside echo. In the bedside echo, there was a large fluid collection around the heart, and then on parasternal view, we could see a floating heart in the fluid, and right atrium and right ventricle was collapsing. So we came to a diagnosis of pericardial effusion. At this point of time, also ABG was taken due to the respiratory distress, and ABG was showing a pH of 7.34, PCO2 18.7, bicarbonate 9.8. Patient had a lactate of 13.6. ABG was showing severe metabolic acidosis.
So why is that lactate 13.6?
Due to the severe respiratory distress, tachypnea, patient was having tachypnea.
Tachypnea will be there, desaturation will be there, and because of reduced cardiac output. This patient BP might be high because of the distress and all. This reduced cardiac output, reduced perfusion can increase the lactate. So now we got a diagnosis. So retrospectively thinking, what were the clinical signs of tamponade in this patient?
Patient initially had breathing difficulty, which was gradually progressive and increased on the day of the presentation. On examination, patient was having a JVP fullness was there. Patient was tachypnic, and on ECG we had got the findings of
Clinically, a patient will be in pain. Along with that breathlessness will be there. So increased respiratory rate, then desaturation will be there, and hypotension also sometimes will be there, and tachycardia will be there. Okay, and other signs are the elevated JVP, then we will get a pericardial rub and all. And important investigation, we will be doing an ABG mainly we will be seeing a lactic acidosis because of reduced perfusion and hypoxia. Then in then what else will you see? ECG. What will you see? Tachycardia
will be there. Low voltage complexes will be there.
And sometimes we will see alternates also. Then what other Bedside? Echo we will be seeing fluid around heart and RARV collapse will be there. All the ventricles and atria will be collapsed, and IVC also will be dilated. Okay. Then X-ray, chest X-ray.
Chest X-ray, there can be a cardiomegaly. The borders of the heart will be very prominent on the chest PA view.
Okay.
Coming to the sample history, patient 63-year-old male.
So at this point of time, after diagnosing this, we need to arrange for the pericardiocentesis set should be arranged, and 2 large bore IV cannula already you have placed. Okay. Suppose this patient's initial BP was only 80/40. What will you do?
If the BP is there, we can give a fluid challenge to the patient, because in the pericardial effusion, blood is not getting into the right ventricle and the stroke volume will be reduced. So in order to increase that, we can give a fluid challenge to the patient, and then take over the patient for pericardiocentesis.
Okay.
Coming to the sample history, 63-year-old male, known case of carcinoma right lung with liver and brain mets, completed external beam radiotherapy in 2023 and with ongoing chemotherapy. Also known case of CKD, presented with complaints of breathing difficulty since last 4 days. It was progressively increasing in nature and worsened at the day of presentation. Patient also complains of orthopnea. Patient also complains of bilateral chest pain since last 4 days, which was of dull aching type. There was no history of fever or cough. Coming to the system examination, there was no pallor, icterus, clubbing or lymphadenopathy, but there was bilateral pedal edema was present. Respiratory system, air entry was bilaterally equal, right-sided wheeze was present. Other systems were within the normal limit. So following this, we had cardiovascular, muffled heart sounds were there. S1, S2 muffled heart sounds were heard.
Okay.
Then we had reassessed the
what
patient.
are the components of Beck's triad?
In Beck's triad, there will be hypertension will be there, muffled heart sounds and JVP elevation will be there.
Okay, so this patient except hypotension, rest two were there. So what might be the cause of pericardial effusion in this patient?
This patient is a known case of carcinoma right lung. So malignancies usually can cause pericardial effusion. One of the most common causes.
Other causes?
Other causes can be any pericarditis can be there. Then any drugs like chemotherapy drugs can also cause pericardial effusion. Then in other patients, it can be any connective tissue disorders can cause, hypothyroidism can cause, any prior cardiac surgeries can cause, aortic dissection, MI, any blunt chest traumas also can cause.
Okay, so this patient contributing factors might be malignancy metastatic. Then patient is on radiotherapy. So radiotherapy can cause pericardial effusion, and also CKD also. Renal failure can also cause. Okay, so 3 contributing factors are there. Okay, or otherwise viral infections or autoimmune conditions or thyroid abnormalities. Okay, and traumatic. Okay, what was done for this patient?
This patient, we had given a cardio consultation and patient was taken to the cath lab for a pericardiocentesis, and on arrival at the cath lab, the patient has deteriorated and BP had fallen. At the arrival of cath lab, it was 110/80, and then further it fell down to 80/40 mmHg. So they had done on an emergency basis, pericardiocentesis was done. There are 3 approaches for the pericardiocentesis, and the most commonly used is subxiphoid pericardiocentesis.
Before planning the approach, we need to think how to do pericardiocentesis. Okay, so pericardiocentesis can be done in different ways. Do you know the ways? 4 ways.
There are mainly 4 approaches.
And not the approach. Either you can plan if it is like a stable patient and all. We ideally don't do pericardiocentesis in all routine cases. Only if the patient going to hemodynamic instability or in a peri-arrest state, we will be doing it in ER. Otherwise, we can plan it on 4 bases. Either we can do it as a fluoroscopy guided pericardiocentesis can be. That is a safer option. So that fluoroscopy that sheath can be kept there, and we can slowly aspirate the fluid. Initially we can aspirate up to 200 to 300 ml so that the patient will be hemodynamically stable. Then we can slowly take it. What will happen if you suddenly decompress the pericardial fluid? It can cause pericardial decompression syndrome. So that should be avoided. So ideally you can do it by fluoroscopy and sheath insertion, or other way is we can do a CT guided pericardial aspiration, or in unstable patients in ER we can do echo guided pericardial fluid aspiration, or if that is also not available, then only we will plan on doing blind approach. Okay. So before planning on doing this procedure, we need to what all things will you do before you are planning to do a pericardiocentesis in the ER. So this happened in the cath lab. If you are planning to do in the ER, what all things will you arrange? How will you plan on doing?
For a pericardiocentesis, 18 gauge spinal needle should be arranged. Then
that is for adults. 18 gauge spinal needle. In children, 20 gauge spinal needle. Okay.
20 gauge needle should be arranged. Then patient should be given local anesthetic before the procedure.
Then before local anesthetic, what should you do?
Cleaning and drape.
Before planning on any procedure, any invasive procedure or procedures that can cause a life-threatening event to the patient, we need to take an informed consent from the bystander. Then we need to arrange the things. What all things will you arrange?
18 gauge needle should be there, a 10 cc syringe should be there, loaded with normal saline. 3-way should be there.
Then what all things to arrange?
Then local anesthetic should be there.
So procedural sedation, that is very important. So if the patient is conscious and all, we need to start on oxygen, connect the defibrillators, everything, start IV fluids, and give a low dose of any sedative agent, and analgesics should be given. So procedural sedation, consent, then positioning. How will you position?
30
degree head and elevation should be there. Why can't you keep the patient supine? Because pericardial fluid is, for the gravity effect, it will come down if you are keeping 30 degree head and elevation. If you are keeping the patient supine position, it will go behind the heart. So for the gravity effect, we need to position the patient 30 degree head and elevation. Okay. And we need to arrange the equipments, take a consent, then procedural sedation, positioning the patient, and echo. So you have told 3 approaches. What are the 3 approaches?
Subsiphoid approach can be there, parasternal and apical approach.
Okay.
Usually we do subsiphoid approach.
So what probe will you use if it is subsiphoid approach?
Echo probe will be used.
If subsiphoid, it is from the abdomen we are doing, so you can use the curvilinear probe. Rest 2, you can either use a 4 to 8 hertz probe or a echo probe can be used. Okay. So subsiphoid, how will you enter?
We usually insert the needle 1 centimeter below the subsiphoid, pointing towards the left shoulder at a degree of 30 degree.
Okay. How much centimeter should you go in? Ideally, when you are going 30 degree subsiphoid towards the left, directing towards the left shoulder, you will be going, and you need to aspirate each time and see. And while you are going, you need to go at least 7 to 9 centimeter in case of an adult. Okay. And in an inclination of 30 degrees. If at all you are not getting a fluid, then we will have to remove partially, and we will have to incline 30 degree more up or down, and then we will have to insert in. Okay. So what are the complications expected if you are going through subsiphoid approach? You are going through the abdomen. So what will happen? peritonitis can happen, any hollow viscous injury can happen, then left lobe of liver might get injured. And another one is that if you're going through subxiphoid approach, there is a chance that you will be entering the pericardium near the right ventricle, and right ventricular thickness is very much less, so we might not know whether we are penetrating into the right ventricle or not. So because right ventricular is not very thick, so right ventricular injury also we might miss. Okay. What is the other approach?
Other one is like parasternal approach can be done, but we usually do not prefer the parasternal approach because it can injure the internal mammary vessels.
That is the most common complication. So if at all we are planning to do, where will you do? In the fifth intercostal space. Fifth intercostal space, we will be inserting it perpendicularly and we will be simultaneously aspirating and seeing. Then what is the third approach?
Next is like apical and apical we do not prefer because of the risk of the pneumothorax, because there is left pleural space. So anticipating pneumothorax, we usually avoid the apical approach.
So if at all we are planning to do, we will be doing it in the fifth, sixth or seventh intercostal space, 5 centimeter from the sternum, and we will be directing towards the right shoulder. So subcostal left shoulder, this one directing towards the right shoulder. And as you told, the most common complication for this one is pneumothorax. For parasternal, most common complication is injury to the internal mammary vessels. Okay. So if at all you are doing in the bedside and you are getting with the spinal needle, you are aspirating a fluid, what will you do? We need to connect it with 3-way. Then
we should collect the fluid for the further studies. We have to send for cytology, gram stain, then
not for
TCDC.
sending. How will you fix it? Because what will happen is patient will be in distress, patient will be breathing in and out. We need to make sure that we are stabilizing the needle there properly. If at all we are coming out and if we are repuncturing, there is high chance of puncturing onto the ventricle. There is high chance of puncturing onto the coronary vessels, and this can cause bleeding into the pericardial space, and this might clot the pericardial fluid. So we need to fix the needle in position. Then we need to connect the 3-way. We need to aspirate and push to the IV set, and then we need to slowly drain. How much maximum will you drain?
Up to 1000 ml can be drained.
1000 ml was drained in this patient, but ideally do not drain more than 500 ml. With 200 to 300 ml of draining of pericardial fluid, patient we will be able to get the hemodynamic stability we might get. But don't drain more than 500 ml at a stretch, because that can cause pericardial decompression syndrome. Patient will go into pulmonary edema, distress and all. So a maximum up to 500 ml. Okay. Then if we have a facility to put a sheath, that means if our other than spinal needle, if we are directly going and if we are dilating with the 6 to 8 French sheath, if we are able to insert, then we will be able to keep that sheath in position there. So before that we need that guide wire, rest of things, and so we will be able to keep that sheath. After removing 500 ml, we can wait. Then after some time we can slowly remove, so that we can prevent that decompression syndrome. Okay. And also note that we need to, what will happen if we are keeping a catheter in the pericardial space? What are the complications?
It can lead to infection, bleeding.
Infection will be there then. It might clot, because anyway while puncturing you might puncture 2-3 times, and it is very vascular area, so there is high chance of it to get clotted. Even the pericardial fluid itself will get clotted. So to prevent that, we need to give saline, heparin with saline flush should be given every 4th hourly or 6th hourly. That also should be given, and we need to aspirate fluids. Okay, so what are the complications which you expect during the procedure?
We can puncture the right ventricle, puncture can be there. Injury to the vessels can be there. It can cause pneumothorax. The clot, as ma'am told, clot can happen in the fluid, pericardial fluid.
So what will happen if there is clotting in the pericardial fluid? That will cause stunting of the heart, and patient might go into cardiac arrest and die. Okay. And other injuries, if you are proceeding through the abdomen, abdominal injuries, liver injuries can happen. pneumothorax can happen, injury to the internal mammary vessels, and rest complications can happen. And if you are successfully entering inside also, pericardial decompression syndrome also can happen. Okay. These are the complications. So when will you, so this patient, what happened?
This patient was taken for immediate pericardiocentesis and 1000 ml of pericardial fluid was drained out.
Okay.
And now patient is presently in the CCU.
Okay. So when will you plan on removing this pericardial? This patient they might have placed a sheath or something. When will you plan on removing this? So we will be aspirating, slowly decompressing the pericardium, and if we are getting only less than 25 ml in 24 hours, then we can remove this. Okay. Less than 25 ml in 24 hours. Okay. So this patient had a pericardial effusion, which became a tamponade. When the patient was shifted to the cath lab, patient into hypertension and was a pericardial tamponade. So which all tamponade? If this tamponade happened in the ER, we might have done in the ER itself. When will you plan on immediately taking to OT other than decompressing in the ED? So we have told different types of pericardial tapping, pericardiocentesis and all. When will you plan on directly shifting to direct surgical intervention? When is it required?
Massive pericardial effusion is there.
Massive can be tapped, no. If it is traumatic, like if it is a secondary to trauma, that means a major vessel is bleeding inside. So that will require immediate surgical intervention. Or if it is iatrogenic, some patient, someone might have been done some surgeries or during some invasive procedure like ICD insertion and all. If we are accidentally injuring to the heart and causing a pericardial tamponade, that requires surgical intervention. Then MI which has led to ventricular rupture, that requires surgical intervention. Then in type A aortic dissection, these 4 conditions we will have to do. So type A aortic dissection, MI causing ventricular rupture, then which are iatrogenic and traumatic causes. This will require surgical intervention more than pericardiocentesis. Okay, and what happened to the patient?
Patient is now hemodynamically stable
in CCU.
CCU.
Okay. Any studies were done?
Yes, pericardial fluid was sent for and the cytology came positive for malignant cells.
So it was malignancy related. Okay. Anything else? Okay, thank you.